All right, everyone. Welcome to Chapter 17, Cardiovascular Emergencies. This is definitely one of the most important chapters in the entire course, really because heart disease is still the number one cause of death in the United States. Chances are, if you work in EMS, you'll respond to more chest pain and more cardiac arrest calls than almost anything else. So what we're learning here isn't just going to be your test material. It's stuff that's going to make a difference in your community. In this chapter, we're going to walk through the basics of how the heart works, what happens when it doesn't, and most importantly, what you can do as an EMT. We'll also look at things like angina, heart attacks, heart failure, high blood pressure emergencies, and of course, cardiac arrest. We're also going to connect the dots between your assessment, treatment, and transport decisions so you'll know not only what to do, but also why it matters. By the end, you really should feel confident recognizing the red flags, starting the right interventions within your scope of practice. Things like oxygen, aspirin, nitroglycerin, and getting your patient to definitive care as fast as possible. So, with that big picture in mind, let's start by looking at, again, the National EMT Education Standards, which is going to spell out exactly what you're expected to know and do in cardiovascular emergencies. All right, so now that we've kind of set the stage, let's look at what the national standards say you should be able to do at the EMT level when it comes to cardiovascular emergencies. Now, these standards aren't just boxes on a list, they're really the foundation of your role in the field. The first piece is going to be your pathophys. That's just, a fancy way of saying you should understand in simple terms how the body is supposed to move blood and oxygen and what happens when that process actually breaks down. You don't need a, cardiologist depth of knowledge, but you do need to know enough to recognize when perfusion, and that's when blood flow to the tissues, isn't working the way it should. The second part is just the medicine. As an EMT, you're really expected to provide basic emergency care and ultimately safe transport for your patients who are acutely ill. In cardiac calls, that means quick recognition, systematic assessments, and using the tools within your scope oxygen, aspirin, assisting with nitro, positioning the patient, and utilizing the AED and CPR when necessary. So as we move throughout the chapter, just keep those competencies in mind. They're really the backbone of everything else we'll cover. Next, we're going to look at specifically cardiovascular competencies you'll be tested on, and more importantly, what you'll be expected to perform in the field. All right, how do I go to the next slide? Enter. Okay, I'm not going to delete this. Hold on. Sorry about that. Had a little technical difficulties, but now this next group of competencies really zooms in on the cardiovascular system itself. You should be able to recognize, manage two really big emergencies, right? Chest pain and cardiac arrest. So when it comes to chest pain, your role is to quickly assess whether it sounds like it could be cardiac in nature. Patients don't always say, I'm having crushing chest pain. Sometimes they'll describe it as a pressure, discomfort, tightness that might spread somewhere else in the body, like the arm or the jaw. Other times, especially in women, elderly patients, or people with diabetes, the signs are more subtle, like shortness of breath, just a little bit of nausea, just feeling off. So your job is to recognize those patterns and treat it seriously until you're proven otherwise. For cardiac arrest, your responsibility is clear. Start high quality CPR, get the AED on the patient as quickly as possible. Every second counts, and survival is directly tied to how quickly chest compressions defib and when it started. So these competencies really remind us we don't need to diagnose every possible cardiac condition. We just need to recognize the problem, stabilize the patient, and get them moving towards definitive care. Now let's go ahead and look at a deeper dive into the specific diseases and conditions that really fall under this umbrella. So here are the core cardiac problems, okay? And we're going to talk more about them, but you'll see as an EMT. First, it's acute coronary syndrome or ACS. This umbrella term really for any situation where their heart muscle isn't getting enough blood. Under ACS, you'll hear two big terms, angina, which is temporary chest pain from decreased oxygen, and myocardial infarction or an MI, which is when the heart muscle actually starts to die because the blood supply is cut off. Another condition on this list is going to be your aortic aneurysm or dissection. This is when the largest artery in the body weakens or even tears. It can look a lot like a heart attack at first. You have sudden severe chest pain, but there are subtle clues like tearing or a ripping sensation, or a difference in blood pressures in the arms. The important takeaway for you is if someone has chest pain or discomfort that seems cardiac in nature, you treat it as an emergency no matter what. You don't have to know exactly what the diagnosis is. You just need to recognize the seriousness and act quickly. So to really round out the list, again, we're going to talk about 3 more conditions. We kind of already hit on them, but let's talk about thromboembolism. Okay, that's when clot forms in one place and then travels until it blocks blood flow somewhere else. More specifically, the coronary artery. That's one of the most common ways a heart attack will actually begin. The second is heart failure. So this happens when the heart can't pump strongly enough to keep up with the body's needs. On scene, you're actually going to often see patients with heart failure struggling to breathe or anxious. They might be sitting upright just to try to get some relief. They might be coughing up pink frothy sputum if the fluid has built up in the lungs. The third is going to be your hypertensive emergencies. Most people with high blood pressure don't feel it, but when it gets dangerously high, it can cause severe headaches, confusion, chest pain, or even lead to a stroke or an aortic dissection. As an EMT, you're not treating the underlying disease, right? You're recognizing these emergencies, keeping the patient stable, and really getting them rapidly to the hospital. So that's the consistent theme of all these competencies: recognize, stabilize, transport. Perfect. All right. So when we talk about cardiovascular emergencies, it's really important to understand the scale of the overall problem, right? Heart disease has been the leading cause of death in the United States for well over a century. So right now it accounts for about 1 in every 3 deaths. That means almost every EMT will respond to these types of calls on a regular basis. So this chapter isn't just, again, it's not just academic, it's all about the practicality. Every time you walk into a patient's home and find someone clutching their chest, they're short of breath, or they just collapse without a pulse, you're dealing with the number one killer, okay? The way you assess, the calmness in your voice, the speed in which you apply the AED and your interventions, all of these actions are going to matter. So as we begin, just keep that in mind that cardiovascular calls are both common and high stakes. So you may be the difference between someone walking out of the hospital or not. Okay, so in the next slides, we're going to talk about the specific ways EMTs can reduce deaths from cardiovascular disease, both not only on scene, but across the community. So how exactly can we do that, right? So it really starts before we arrive. All right, communities that focus on preventions, healthier diets, more exercise, less smoking, those communities see fewer cardiac emergencies. But once the call comes in, it's about your speed, your action, okay, your efficiency. Dispatchers play also a critical role. They can recognize cardiac arrest early, give CPR instructions over the phone. Your survival chances double or even triple when before we even hit the door. So when we arrive, it's about doing the basics, right? Immediate, high quality CPR, attaching the AED, recognizing that chest pain that might be a heart attack. Okay. Even something as simple as notifying the hospital early that a possible heart attack is coming in gives them precious minutes to prepare. So the faster a patient gets into a cardiac cath lab or more of the heart muscle can actually be saved. So EMS can save lives not only by treating on scene, but also being that crucial link between early recognition and definitive hospital care. So this last kind of introduction slide really focuses on the systems of care. So one of the biggest changes in the past couple of decades has been placing AEDs in public places, airports, gyms, schools, malls, wherever there's a large gathering of people. Because when people are confident to use them and EMS integrates them seamlessly, sudden cardiac arrest survival rates will climb. We've also moved towards taking patients with suspected heart attacks directly to specialty centers These hospitals are more equipped to perform rapid interventions like stenting or bypass surgery, which can restore blood flow to the heart. But the catch is that they can only really mobilize their team if they know what's coming. So that's where your role as an EMT comes in. A good radio report that describes the chest pain, vitals, any type of risk factors, and what treatments you've given prepares the hospital to move more effectively. Okay. So you can see the systems work best when every link is strong. Early recognition, good pre-hospital care, rapid transport, and rapid transport to the right facility. With that context, let's kind of look into the anatomy and phys. So let's start at the basics again. I know we kind of already covered this in previous chapters, but let's look at the basics of the heart itself. Okay, heart muscular pump. It has one simple job, and that's just to keep blood moving. It's divided into four sides, two sides, four chambers. You have the atria, which are on the upper chambers that receive blood, and the ventricles are at the lower chambers. They do the pumping. Okay. The right side of the heart collects oxygen-poor blood from the body, sends it to the lungs to get reoxygenated. The left side receives oxygen-rich blood back from the lungs and then pumps it out to the rest of the body. So every time you feel a pulse, what you're actually feeling is that left ventricle pushing blood into the arteries. As EMTs, understanding this setup helps you make sense of the emergencies that we're going to cover in the next few slides. If the left side isn't pumping well, you'll see problems like low blood pressure or fluid buildup in the lungs. If the right side is struggling, fluid backs up into the body. You'll have swollen ankles, distended neck veins. So even though this is a basic anatomy, it connects directly to what you'll actually observe in your patients. So now moving on, here you can see, again, this is a more anatomically correct picture, four chambers of the heart and the valves that keep the blood flowing into one specific direction. You want to think of valves as kind of doors that open and shut with every beat of the heart. On the right side, blood moves from the right atrium through the tricuspid valve into the right ventricle. Then to the lungs. On the left, the blood passes from the left atrium through the mitral valve into the left ventricle, and then through the aortic valve in the body. As EMTs, you don't need to memorize every detail of valve anatomy, but you do need to understand the big picture. The heart works like a two-sided pump, okay? And the valves make sure that there is no backflow. When valves fail or the ventricles can't keep up, you'll see signs of congestion, fluid in the lungs, or the swelling in the extremities. So this diagram is here really to help you picture those flow patterns so that you can better connect what's happening inside the chest with what you see on the outside. I do plan on making a separate video detailing the pathway of blood through the heart so you can kind of understand it a little bit more, but that'll come a little bit later. So again, let's reinforce the one-way nature of blood flow for those valves. Every beat depends on the valves opening and closing at exactly the right time. So when the left ventricle contracts, the aortic valve swings open and blood surges forward into the aorta, where the mitral or bicuspid valve shuts tight to prevent that backflow. The same pattern happens on the right side with the tricuspid and pulmonary valves. Why does this matter for you in the field? Again, because when forward flow is disrupted, that's when your perfusion will drop. A patient with valve disease or weakened ventricles may look like a classic cardiac patient, shortness of breath, low blood pressure, signs of shock, even if the arteries themselves are open. So again, you won't be diagnosing valve problems as an EMT, but knowing that the heart relies on this careful timing helps you understand why some patients will decompensate so quickly. So again, here's another good diagram showing the two sides of the heart kind of in action. The right side, again, is responsible for sending deoxygenated blood to the lungs, while the left side handles the pumping, the pumping that freshly oxygenated blood out of the body. I like to think of them as like two pumps working in a series. The right heart is the pulmonary pump. The left heart is the systemic pump. This distinction really helps you interpret what you're seeing in your patients. If the left heart fails, fluid backs up into the lungs, and your patient will come to you with shortness of breath, coughing, possible pink frothy sputum. If the right heart fails, then the blood backs up into the body, and you'll see those swollen legs, ascites or distended neck veins. Of course, over time, the failure of one side often leads to the other, but recognizing the patterns can help you paint a picture of really what's happening. So with that in mind, let's go ahead and move on from the mechanics into the heart's actual electrical system. There we go. So let's talk about the electrical system or the conduction system. Okay, the mechanical pump only really works because it's driven by electricity. Okay, it all starts in the sinoatrial node or the SA node, located in the right atrium. That's kind of the heart's natural pacemaker. The signal then travels to the atrioventricular node, the AV node, which delays the impulse just long enough to let the atria empty into the ventricles. From there, the signal will actually shoot down the bundle of His and through the Purkinje fibers, causing the ventricles to contract in kind of a coordinated way. So the key idea here is what we call automaticity, okay? That's the ability of the heart muscle cells to generate their own electrical impulses. That's why the heart can actually keep beating even outside the body for a short time. And it's also why the rhythms can become disorganized. For you as an EMT, really the practical takeaway is that when the electrical system fails, cardiac output is going to plummet. Okay, so that's when patients collapse, and that's when you're going to step in with CPR and the AED. So here again, we can actually see a little bit more visually of how the conduction system is laid out. You have, again, the SA node on the top, AV node in the middle, and then the Purkinje fibers system at the bottom, okay? So this picture is really just a reminder, a representation that the heart beats in a specific sequence. Atria first, ventricle second. When the order breaks down, and like in ventricular tachycardia or fibrillation, the ventricles may be firing so fast or so chaotically that no real pumping is actually happening. So that's where your AED comes into play. Okay, that device will analyze the rhythm and, if appropriate, deliver a shock. The shock doesn't jumpstart a stopped heart. It actually stops the chaos so that the SA node can take back control and restore that organized rhythm. Okay, that's why we really stress quick AED use. The longer the heart actually fibrillates, the less likely it will respond to a defibrillation shock. So as EMTs, your focus is not on interpreting these complex rhythms, but on recognizing pulseless patients and getting the AED on them right away. So let's kind of connect the heart to the nervous system, okay? The autonomic nervous system is kind of the automatic part of your body control. It runs in the background and adjusts things like heart rate, blood vessel tone, really without you having to think about it. There are two branches. You have the sympathetic nervous system, and that's going to be your fight or flight response. That's what's really going to speed up the heart. It makes it makes it contract harder. So your contractility increases. It tightens the blood vessels to maintain pressure. So that's going to be your PVR. You'll see that patients who are pale, sweaty, tachycardic, when they're compensating for shock or ischemia. The parasympathetic nervous system is that rest and digest side, okay? It allows the heart to, slow down, allows blood vessels to relax. Sometimes this system overreacts, like in a vagal faint, and that's the patient's heart when the heart rate and blood pressure just drops suddenly. So for EMTs, it's less about memorizing the pathways and more about recognizing the kind of the fingerprints of these systems in your patient's presentation. Are they kind of revved up and tachycardic, or are they suddenly bradycardic and dizzy? Those clues really help you piece together what's going on, and it helps you better treat the patient. Okay, all right, so the heart muscle, right? So the heart muscle is actually called myocardium. It's one of the really the hardest working muscles in your body. Unlike skeletal muscle, it never rests. So to keep contracting, beat after beat, it needs constant flow of oxygen and nutrients. So that flow comes from the coronary arteries. The heart itself can increase its output by beating faster or squeezing harder. Both increases oxygen demand. If that demand outpaces supply, the myocardium actually becomes ischemic. So that's what patients feel as angina or chest pressure. Think of a patient like shoveling snow, right? Their heart is working harder, oxygen demand goes up, but a narrowed artery can't deliver enough supply. So they get chest pain. For us in the field, this is kind of like the big picture. Any imbalance between oxygen supply and demand can produce ischemic symptoms. And our interventions, oxygen, aspirin, nitro, rapid transport, are all aimed at really restoring the balance or just preventing further damage. So next, we're going to kind of specifically look at where those coronary arteries branch off and why the blockages are so dangerous. Once this slide goes to the next one. Perfect. So here we see that really coronary arteries come right off the very beginning of the aorta, okay? Just above really the aortic valve, okay? That placement ensures that the heart muscle really gets the freshest, like most oxygen-rich blood with every single contraction. The right coronary artery supplies most of the right heart and part of the conduction system, where the left coronary artery is going to branch quickly into the left anterior descending and circumflex arteries, which is going to supply the left ventricle, which again is the main pumping chamber for that systemic circulation. So this is really why heart attacks are so dangerous. If one of these arteries is blocked, the muscle downstream begins to die within minutes. So for EMTs, the key point is not really memorizing, every artery name, but recognizing that coronary perfusion is really a fragile and 10 times sensitive issue. The sooner blood flow can be restored in the hospital, the more muscle can be saved. Okay. And on the next slide, we're going to look at a diagram that really maps out these arteries visually, which will help you kind of connect the anatomy to the conditions that we're going to cover in a little bit. So here we can actually see, like I talked about, the coronary circulation from both the anterior and posterior aspects of the heart. So notice how the arteries kind of wrap around like kind of like a network of highways, like feeding different regions of the myocardium. The left anterior descending artery, that's often nicknamed the widowmaker. Okay, it supplies a large portion of the left ventricle. When it's blocked, the outcome can be deadly without immediate interventions. Okay. So for you as EMTs, like really the practical takeaway is very simple. Chest pain just means that one of these highways could be blocked. So your quick recognition, aspirin administration, nitroglycerin assistance if it's appropriate, and rapid transport are all designed to protect as much as of that heart muscle as possible, really until that hospital can reopen that artery. So think of yourself as just buying time for that cardiologist to clear that blockage. Okay. All right. So now we're looking at the major systemic arteries. Okay. So these are the large vessels that are going to carry the oxygenated blood throughout the body. This is going to include the carotid arteries in the neck, which we often check in cardiac arrest, the brachial and radial arteries in the arms, where we'll take blood pressures and pulses, and the femoral and tibial arteries in the legs. Now, why does that actually matter to you as an EMT? Because assessing these arteries tell you about circulation, tells you about perfusion. If you can feel a strong radial pulse, you know that the systolic blood pressure is at least around 80 millimeters of mercury. Okay. If you lose that radial, but still have a carotid, then you know that the blood pressure is lower and perfusion is compromised. Okay. If the pulses are unequal between the limbs, that might suggest something like an aortic dissection. Okay. So checking different pulses shouldn't just be a routine you do. It's really a diagnostic kind of tool at the EMT level. Okay. So if we look at this, the left and the right carotid artery, that's going to supply the head with oxygenated blood. okay? The left and right subclavian, that goes underneath the clavicle, so that's going more to your upper extremities. Your brachial is going to be in your upper arm, then all the way more distal to your wrist, you're going to have the radial and the ulnar arteries, okay? Going more inferior, we have our right and left iliac, so now we're more towards the pelvis. Then we got our femorals, which is again is going more posterior. Now we're in like the inguinal fold of the groin area. Going lower, more inferior, we have our popliteal, which is behind the knee. Then all the way distal to our feet and ankles, we have our dorsalis pedis and our tibialis posterior. I don't know why we're having issues today with my PowerPoint slide not going to the next one. Let me hit enter. Okay, let me pause and go to the next one. All right, so we've talked about the large arteries, right? So now let's zoom down to the smaller vessels where kind of the real exchange happens, right? Blood travels from arteries into arterioles, then into capillaries. And the capillaries are the tiniest vessels in the entire body, okay? Billions all over. So this is where that oxygen leaves the blood and enters the tissue, and carbon dioxide and waste products move into the blood to be carried away. So from here, the blood flows into venules and eventually larger veins that return it back to the heart, right? So now, why does this matter at the EMT level? It's really because the health of those capillaries show up in your assessment. A capillary refill, especially in your children, pediatric patients, is a quick way to check if circulation is adequate. Pale, cool, mottled skin tells you that those capillaries aren't being filled efficiently. So even though you can't see capillaries directly, you read their function through skin color, temperature, and their refill time. That's why these tiny vessels play such a big role in your kind of decision making. So next we're going to kind of look back at what's actually inside the blood that makes all of this kind of possible, right? Because blood really is more than just the red stuff, right? It's made up of several different parts, each with a different job, right? Red blood cells, right? The erythrocytes. Those cells carry oxygen using the hemoglobin, and they're the reason the blood is actually red. Now, white blood cells, the leukocytes, fight infection, rushing in when the body senses bacteria or viruses. Your platelets help form clots when vessels are injured, sealing leaks. And then you have the plasma, which is the liquid portion that carries the nutrients, hormones, and the waste products throughout the system. So at the EMT level, you won't measure these components directly, but you'll see that you'll see the effects when something's off, right? An anemic patient who doesn't have enough red blood cells may complain of fatigue, shortness of breath. Someone on blood thinners may bleed longer after even just a small injury. So these details matter when you take a sample history, right? Knowing medications and conditions give you kind of the clues about what might complicate a cardiovascular emergencies, okay? So let's look at blood pressure, right? So blood pressure is simply the force of blood, right, against the walls of the arteries. The top number, which we call the systolic pressure, reflects the pressure when the left ventricle contracts and kind of pushes blood out. The bottom number is the diastolic, right? So that reflects the pressure when the heart relaxes and just refills. So together, these numbers give us a snapshot of really how well is the pump working and how tight or relaxed the blood vessels are. But the key here is you don't want to rely on the numbers alone. Okay, a patient might have a normal reading blood pressure, but look pale, sweaty, confused. That tells you perfusion isn't adequate despite what the cuff says, right? On the other hand, right, very high blood pressure with neurologic symptoms could signal a hypertensive emergency. So as an EMT, you're really looking at the whole picture, the holistic patient, vital signs plus skin signs, mental status, and overall appearance. So blood pressure is just one piece of the puzzle, okay? Right? You want all the pieces of that puzzle to see the entire picture, right? Now, sometimes you could get one puzzle piece and have an idea what the picture might be, but really you want to start collecting all those puzzle pieces, put them together, and then that gives you the entire picture. Now here, pulses, right? We've covered pulses quite in depth in lab, but pulses, which ones is really one of the quickest tools to check circulation. You have central pulses like the carotid, the femoral. Those are deeper, closer to the heart. We use them more in critical situations like a cardiac arrest situation because they persist even when blood pressure is very low. Your peripheral pulses, like the radial at the wrist or the dorsalis pedis in the pulse, they're more sensitive. They're going to be the first ones to really fade when circulation starts to fail. Your pulse checks also tell you more than just the presence or absence, right? It should notice rate, the strength, the regularity. A weak thready pulse may point to shock. An irregular pulse can mean an underlying dysrhythmia. And comparing one side to the other, that also matters, right? If the right radial pulse feels strong, but the left is weak, that could indicate some type of vascular problem like an aortic dissection. So when you're taking pulses, don't just count, right? Pay attention to the quality and the symmetry. Um, and again, we know how to take a pulse. In terms of what I want you to do, when you have like an unconscious patient, you go straight to the carotid or femoral pulse, right? If you have a more medical type patient who's conscious, you'll do less invasive. You'll do a radial pulse. Very simple. Now, how do you check that? How do you check those pulses? Again, you're going to use two fingers, whether it's your index and middle or middle and ring. It's up to you. Never your thumb. You're just feeling for that pulsation. You want to make sure that you don't press too hard. You don't press too lightly. Pressing too hard, you can occlude that artery, and now you're stopping blood flow. So now you don't feel a pulse. Pressing too lightly, you're just feeling the skin rather than the underlying vessel. Okay. I do recommend kind of playing around. Do you like the index and middle or middle and ring finger? And then also practice with gloves on. Okay. That glove adds an extra layer of, essential skin to your skin. So it makes things a little bit harder to feel. All right. So make sure to practice this in lab. And then how do we calculate it, right? So best practices, you calculate within a 30-second time window. How many pulsations did you feel? You multiply it by 2. If the pulse is irregular, you want to count for that full 60 seconds, right? We're trying to see how many times is that heart contracting in a full 60 seconds, 1 minute. So here, this slide really ties all the anatomy together with, again, the two key ideas, cardiac output and perfusion. Your cardiac output is simply the amount of blood that the heart pumps in 1 minute. It's calculated as heart rate times stroke volume, but you don't need the math. Just remember that both speed and strength matter, okay? If the heart rate is too slow or the pump is too weak, your output falls, okay? If it's too fast, the ventricles don't have time to fill, and the output will also drop. Okay. Perfusion itself is the delivery of oxygen and nutrients to the tissues. Okay. So when cardiac output and blood pressure are adequate, perfusion is good. When they fail, you'll see pale or cyanotic skin, altered mental status, weak pulses. Okay. So as EMTs, your assessment focuses on spotting when perfusion is threatened or already failed. Okay, so this is the common thread through all the cardiovascular emergencies, protecting circulation to the brain, the heart, the vital organs. Okay, with the anatomy foundation now laid out. Okay, so we're going to shift into pathophysiology and kind of look at the actual problems and how they disrupt the entire system. So let's move on to really what goes wrong, right? Starting with chest pain. Most chest pain we'll deal with in EMS comes from ischemia. Okay. That means part of the heart muscle isn't getting enough oxygen. That's the umbrella of ischemic heart disease. Okay. For you, this means every time you're called for chest pain, your first thought should be, is this cardiac until proven otherwise, right? Because ischemia can present in lots of different ways. You could have classic chest pressure, but also shortness of breath, nausea, or just feeling weak or anxious. So your role is to identify when the pain could be ischemic, start interventions within your scope, and get the patient moving to definitive care. Okay, because remember, chest pain is one of the most common complaints that you're going to have, and you should never downplay it. Okay, treat it as serious, and let the hospital rule out the minor stuff. Okay, so now let's kind of look at the underlying cause for most ischemic heart disease, and that's going to be your atherosclerosis. Okay. Over time, you can develop fatty deposits. Okay. This is going to be made up of cholesterol, calcium, and the buildup is inside the actual walls of the arteries. These plaques really narrow the vessels and make it less flexible. Okay. So when this actually happens in the coronary arteries, it means less blood can get to the myocardium, especially during exertion. Okay. So when you're actually utilizing or doing any type of physical activity, that narrowing sets the stage for angina or even a possible full-blown heart attack if that plaque ruptures and a clot actually forms. Think of it like a plumbing, right? If the pipes are clogged, water flow will drop, right? If a chunk breaks off and blocks the pipe completely, nothing can possibly get through. Patients with atherosclerosis might not feel anything until the blockage becomes severe. And that's why the first sign can just be chest pain or even a sudden cardiac arrest. So for EMTs, the most important point is that atherosclerosis is really the root problem behind many of the cardiovascular emergencies you're going to see. So on the next slide, we're going to talk about really what happens when those plaques turn into clots and block the artery completely, right? So again, when that piece of plaque, right, it ruptures, the body responds by forming a blood clot. Sometimes that clot stays put and narrows that blood vessel, okay? Other times it breaks off, travels downstream, and then until it wedges into a smaller artery, okay? That's what we're going to call a thromboembolism. In the coronary circulation, a thromboembolism can actually completely block blood flow to part of the heart muscle. Within minutes, these cells begin to die. All right, this is how an acute myocardial infarction or a heart attack will develop. Okay, now as an EMT, you can't see the clot, okay, but you can recognize the effects: sudden chest discomfort, shortness of breath, sweating, weakness. That's why rapid recognition, rapid treatment are so critical. If we can get aspirin on board to help prevent further clotting and get the patient to a hospital quickly, we can buy time for the interventions like clot busting drugs or stenting. Okay. And we're going to look at those relatively soon. But first, let's kind of look at how common coronary artery disease is and why it's still the leading cause of death. Testing 1, 2, 3, testing 1, 2, 3. So now we get to acute coronary syndrome, okay, or ACS. So think of ACS as kind of like an umbrella term for conditions, again, where the heart muscle just isn't getting enough oxygen. Under that umbrella, we have angina pectoris and a myocardial infarction. Angina is more of a kind of a warning sign. It's when the heart muscle is temporarily starved of oxygen, often because the coronary artery is narrowed, but not completely blocked off. Okay. A myocardial infarction, on the other hand, is the full-blown heart attack, when part of the heart muscle begins to die due to total blockage of that coronary artery. Now, as an EMT, your role isn't really to decide whether it's chest pain is angina or an MI. You're going to treat both the same. Now, if someone is having chest pain of possible cardiac origin, you assume it could be an MI until proven otherwise, right? That means calm assessment, oxygen if indicated, aspirin, nitroglycerin if it's appropriate, and then again, rapid transport. On the next slide, we're going to dive a little bit deeper into angina pectoris and kind of what makes that specific pathology kind of unique. Angina pectoris literally means chest pain, okay? And it happens when the heart muscles oxygen demand temporarily kind of outstrips, if you will, the supply. Okay, so the classic description is going to be crushing or squeezing discomfort in the chest that may radiate to the jaw, the arm, the back. Angina is most often triggered by exertion like climbing stairs, shoveling snow, and it typically goes away with rest, oxygen, or nitroglycerin. Patients with known coronary artery disease may carry nitro tablets or a spray for that specific reason. The key point for you specifically, angina is a red flag. Even though it may resolve, it signals that the patient has underlying coronary disease and they're at a high risk for a heart attack. So when in doubt, always treat angina as a cardiac emergency. Don't be reassured just because the pain subsides. It still warrants assessment and rapid transport. Now let's kind of talk about the difference between stable and unstable angina. So stable angina kind of has a predictable pattern. Okay, the patient knows that when they exert themselves, the chest pain will start. Okay, and when they rest or take their nitroglycerin, it goes away. Okay, it's really consistent, right? On the other hand, unstable angina is unpredictable, right? It may occur at rest, last a lot longer, and be harder to relieve. Okay, this is obviously more dangerous because it usually signals that an acute myocardial infarction is gonna happen. For EMTs, you don't need to label which type of angina the patient is having. If chest pain is new, more severe, or just different from their usual pattern, that's when you're going to treat it as if it was unstable. And then again, get the ball moving. The hospital will sort out really the details there. The bottom line is that the unstable angina is treated the same way as a suspected heart attack, again, until it's proven otherwise. Uh, Now, let's talk about the myocardial infarction or an MI. That's your heart attack, okay? This is when the blood flow through a coronary artery is completely blocked, okay? Now, it's usually by a clot that's forming on top of the atherosclerotic plaque. When that happens, the myocardium downstream of the coronary artery is starved of oxygen and will begin to die. Okay, the key fact to remember is that time is muscle, okay? The longer that the artery stays blocked, the more heart tissue is permanently damaged. That's why rapid recognition and transport are so critical. Hospitals can reopen that artery with, clot-busting drugs or procedures like stenting. But those really only work well if they're started early. You as EMTs, our role is to recognize the possibility of MI, provide supportive care, get aspirin, assist with nitro if it's indicated, and notify the hospital quickly so that they can prepare. All right. So the faster we move, the more heart muscle we can actually save. So what does an MI actually look like in the field, right? Now, your classic symptoms are going to include chest pain or pressure that may radiate or move to the arm, the neck, the jaw, the back. Patients are often pale, they're sweaty, anxious. They may be short of breath, nauseated, maybe vomiting. Some describe a feeling of impending doom, like they know something is seriously wrong with them. Now, not every patient presents the exact same way. Especially you have your older patients, people with diabetes, women may have what we call, atypical presentations. So instead of crushing chest pain, they might complain of like shortness of breath, fatigue, indigestion, or just weakness. Okay, that's why you need to keep a wide net when assessing possible cardiac patients. Okay. Now, in the field, if you suspect an MI, you need to treat it seriously every single time. You want to give a good, thorough assessment, get a good history. Again, provide aspirin, assist with the patient's nitro, again, if it's appropriate, and prepare for the possibility that the patient could deteriorate rather quickly. Now, this specific slide compares a myocardial infarction with angina. Okay, so angina, again, is usually predictable. It comes on with exertion, it lasts a few minutes, and it goes away with rest or nitroglycerin. Where myocardial infarction is just different, right? The pain often starts very suddenly, but it's going to last a lot longer, typically 30 minutes or more. And it isn't fully relieved by rest or medications. Another key difference is the seriousness, right? Angina, we consider more of a warning sign, but MI means actual heart muscle is dying. So patients may present very similar at first, so you can't always tell them apart in the field, okay? That's why your job isn't to decide, is this angina, is it an MI? Your job is to treat every chest pain patient like it could be MI, again, until it's proven otherwise by the paramedic or at the hospital. Now, that mindset is going to keep patients safe and ensure that you don't miss any life-threatening emergency. So what do you notice in a patient with an acute MI? Okay. First thing is going to be their overall demeanor, right? They may look frightened, anxious. They often describe that sense of impending doom, right? Their skin may be pale, cool, clammy, and that's because circulation is shifting from the skin to protect the vital organs. Now, when you check pulses, you might find them fast, slow, irregular. It really just depends on how the heart's conduction system is being impacted. Blood pressure can also vary. Some patients are going to be hypertensive at first, while others are going to be hypotensive if the actual pump is already failing. Their respiratory rate, it may increase, especially if the fluid backs up into the patient's lungs. Now, what's important for you is to keep tying all of these findings together. Don't just note a pulse is 120, right? Connect it. The pulse is rapid and weak, the skin is clammy, and the patient is short of breath. That really paints a clear picture for the patient of poor perfusion. Document those findings and communicate them to the hospital. Um, Now, an acute MI can really lead to three major consequences. Now, and as an EMT, you need to be prepared for any of them. The first is sudden death, usually from a lethal heart rhythm that like ventricular fibrillation. This is why the AED is such a critical tool. It gives the patient the best chance of survival when that heart rhythm suddenly collapses. Okay. The second is going to be your cardiogenic shock. If the heart muscle is badly damaged, it can't pump enough blood to maintain the pressure and perfusion to the body. Patients may become cold, again, clammy, weak, or even lose consciousness as their circulation fails. The third is congestive heart failure. Okay, so that's when the left ventricle can't pump effectively and blood backs up into the lungs. Okay, so you'll see patients who are short of breath, coughing up pink frothy sputum, and unable to lie flat without the feeling like they're suffocating. Okay, and that's widely dependent on if it's a right side or left side MI, or heart failure. So it's important to recognize these complications early, and it allows you to anticipate the deterioration and again, just act more efficiently and quickly. Dysrhythmias, right? So dysrhythmias are just abnormal heart rhythms, and they're very common after a heart attack. Okay, some are going to be minor and don't really impact a patient's cardiac output. Others are going to be lethal, right? You might have what's called a premature ventricular contraction or PVC. Those are just early beats that come from the ventricles instead of the atria. They can feel like a skipped beat. A few PVCs aren't usually life-threatening, but frequent ones can signal irritability of the actual heart. Tachycardia, that just means that the heart is beating too fast, while bradycardia, it means it's beating too slow. Either extremes can reduce cardiac output if it interferes with the filling and the pumping. The most dangerous rhythms are going to be ventricular tachycardia and ventricular fibrillation. Okay, and that's going to be for you guys. VT is very fast and may still produce a weak pulse, but it often deteriorates into ventricular fibrillation. Now, VF is complete chaos. There's no effective pumping, there's no pulse, there's no perfusion. So, again, your role isn't to diagnose the rhythm. You just need to recognize a pulseless patient, start your CPR, and use the AED. Right, your AED will identify and shock those dangerous rhythms when it's indicated. All right. Now, so let's talk about that AED. So that defibrillation is really one of the most important tools that we have for cardiac emergencies. When the heart is in ventricular fibrillation, it's really just quivering instead of actually pumping. The defibrillation delivers an electrical shock designed to stop that chaos all at once, giving the heart's natural pacemaker, the SA node, a chance to kind of reset and take back control. But it's important to remember, defibrillation doesn't jumpstart a stopped heart, right? It resets a heart that's firing erratically, okay? So an organized rhythm can resume. Now, if the heart is in asystole, that's what we call the flat line, shocking is not going to help, okay? Because there's no electrical activity to reset. That's why recognizing the difference between a pulseless but shockable rhythm versus asystole is also very important, and that's why we rely on the AED to make that call in the field. Now, for EMTs, the priority is just simple. There's two rules. You turn on the AED, you follow the prompts, right? So it's all about recognizing the need for CPR, start your high quality effective CPR compressions, and then get rapid intervention with that AED. Okay. So now let's kind of talk about cardiogenic shock. Okay, so this happens when the heart is damaged, and that it simply can't pump enough blood to meet the body's needs. So it's important to remember that shock means inadequate perfusion, and in this case, it's because there's a failure of the pump. Okay, in the field, you might see a patient who is pale, clammy, restless, have weak pulses, maybe low blood pressure. They may complain of shortness of breath, chest discomfort, but often they look very sick and may seem confused as their brain gets less and less oxygen. Okay. Now, as an EMT, your role is mainly supportive, right? Place the patient in a position of comfort, and that's usually in a sitting up kind of position, like a Fowler's, high Fowler's. Unless they're hypotensive, then they're going to be in the supine. Administer oxygen if it's indicated, and again, prepare for rapid transport. You actually want to avoid giving nitro in suspected cardiogenic shock since their blood pressure is already low. All right. The key is really just early recognition, staying calm, moving quickly towards advanced care. All right. Now, hypertension. Also, this is just our high blood pressure, extremely common. Most of the time, patients don't feel it, which is why it's kind of commonly called a silent killer. But sometimes pressures rise so high that it becomes a hypertensive emergency. This usually means the systolic blood pressure is greater than about 180 millimeters of mercury, along with the signs of organ damage. Now, what does that actually look like in the field? Now, patients may complain of a sudden severe headache. The patient might notice ringing in the ears, a bounding pulse, dizziness, maybe nosebleeds. They may also show kind of neurological changes like confusion, weaknesses, or they might have like stroke-like symptoms. In the more severe cases, the heart can actually fail under this immense strain, leading to acute pulmonary edema. So for EMTs, the job isn't to lower the blood pressure because that's for the hospital, right? Your role is to recognize that it is a serious situation. You need to treat the symptoms like the respiratory distress and then transport rapidly. Now, here we have, again, a little more detailed list of the hypertensive emergency type symptoms. So along with your headache, again, and ringing in the ears, which again we'll call tinnitus, patients may experience nausea, vomiting, dizziness. They might have warm skin, altered mental status, nosebleeds, and signs of heart failure, like potentially shortness of breath. Really, the big idea here is that very high blood pressure can cause your organs to actually fail. The brain, the heart, the kidneys, even the eyes can all be damaged. So that's why we treat these patients again as a high priority. If you suspect a hypertensive emergency, you just keep calm, you monitor the vitals closely, and prepare for rapid transport. So try to avoid letting them exert themselves or become agitated, since again stress can push that pressure even higher. Just oxygen and supportive care are going to be your main tools. All right. And it's important to kind of, again, lessen the stressors inside the back of your ambulance while you're on the way to the hospital. Now, if a hypertensive emergency goes untreated, okay, that's where the consequences can be just absolutely devastating. One of the worst ones is going to be a stroke. Okay, that's where these high pressures damage and rupture blood vessels that are in the brain. Another potential is a dissecting aortic aneurysm. That's where the inner layer of the aorta actually tears and blood begins to separate from the vessel wall. Both of these conditions are considered life-threatening and they require immediate hospital care. Now, from the EMT perspective, your job is, again, recognition, rapid transport. You won't be lowering blood pressures in the field, but you can recognize those red flags, okay? And that's going to be, again, the sudden neurologic changes, the chest pain with a tearing type quality, unequal pulses, or a very high blood pressure with a headache and confusions, right? These clues should raise your urgency levels and, again, prompt you to involve advanced life support. So it's important to remember your role, again, for every single patient you're ever going to have. You want to protect the ABCs, protect airway, breathing, circulation, minimize stress on the patient, and get them to the right facility as quickly and safely as possible. Now, Let's kind of focus now on that aortic aneurysm, okay, and dissections. Now, the aorta again is the largest artery in the entire body, and when the walls of the aorta begin to weaken, it can actually balloon out, and that's what we would. And once it blows up, that's what we call an aneurysm, right? So the if that weakened wall tears, blood is going to start dissecting between the layers of the vessels, and that's called a dissection, okay? And it's immediately life-threatening. Most dissections are kind of linked to uncontrolled high blood pressure, which really puts a constant strain on those vessel walls. So the danger here is, again, just a massive internal bleed, or some type of compromise to the blood flow to those vital organs. Now, from an EMT standpoint, you don't need to diagnose the exact problem, right? You never need to diagnose. You just need to recognize that it's a possibility, right? So if a patient has sudden severe chest pain or back pain, especially if they describe it as tearing or a ripping, and their vital signs seem unusual, like again the different blood pressures on each arm, you should have a high suspicion for an aortic dissection. Now, these patients need rapid transport again to a surgical facility to get definitive treatment. So now here really highlights the presentation, okay, of that aortic dissection. Okay, this really the hallmark is going to be abrupt, severe chest or back pain, and again, these patients are going to subscribe it as kind of a tearing sensation. So unlike a heart attack, which may start gradually, a dissection is suddenly and sudden and extreme from the beginning. Okay. Others includes again difference in blood pressures between arms, weak or unequal pupils, signs of shock. If the bleeding is actually severe, signs of shock. Sometimes the symptoms can mimic a myocardial infarction, so it's not always easy to distinguish. Okay, and that's okay, right? You don't have to. Your role is to recognize that it's a high priority cardiovascular emergency, manage the patient's ABCs, keep the patient calm, transport. Okay, that's it. Because again, these patients may deteriorate suddenly, right? So involving paramedics, ALS, and notifying the hospital early is going to be imperative for the continuity of care and survival of that actual patient. To close out the pathophys section, so whether it's ischemic heart disease, heart failure, hypertensive crisis, aortic dissection, your key responsibilities, again, remain the exact same. Recognize the emergency, provide treatment within your scope of practice, move quickly towards that definitive care. Don't get caught up in trying to determine the exact diagnosis, right? You don't need to know for sure whether that chest pain is a heart attack, if it's angina, it's a dissection. If it looks cardiac, treat it as cardiac until it's proven otherwise. Okay. That approach keeps patients safe and is going to buy them more valuable time. So with that foundation, right, we're ready to kind of shift gears a little bit into the next section. That's where we're going to apply what we learned to our assessment, right? So again, we're going to go through our entire assessment per the specific text. I always recommend whatever program you're in to follow what your instructor wants in terms of the pacing and whatnot and the questions to ask. But by and large, it's all the same kind of components and chunking, okay? Okay, so scene size up. Every single call starts with a scene size up. Okay, and cardiac calls, no exception. First, you got to make sure the scene is safe for you, your crew, your patients, any bystanders. All right. Then take your standard precautions. Obviously, the bare minimum you should have are your gloves, and then consider eye protection. Again, if you anticipate CPR or suction, but you can always add that later on. As you approach, think about the nature of the illness. Chest pain, shortness of breath, collapse, they're all possibilities of a cardiovascular emergency. You could utilize clues from dispatch, maybe family members, or the environment can really help you anticipate what you're walking into. For example, a patient's prescription bottles or a home AED on the wall might hint at a cardiovascular history, right? So there's a lot to kind of set up and to look at. Your scene size really sets the tone. It reminds you to stay situationally aware, anticipate the need for extra resources, prepare for rapid interventions. So once you're confident the scene is safe and you've formed that initial impression, you move on to your primary assessment. Now, in the primary assessment, your goal is to quickly identify and treat life threats. You start with your general impression. How sick does the patient look from the doorway, right? If the patient is unresponsive and not breathing normally, you go straight to your CPR and apply the AED, right? And again, there's a lot more that goes into this. We're just kind of doing a basic overview. If they're breathing and have a pulse, you move into airway and breathing, right? Administer oxygen if their sats are too low, or if they show signs of respiratory distress. Patients in pulmonary edema, CPAP, if it's in your protocol. Next, you move on to circulation, right? You're going to check the pulse, right? The rate, rhythm, quality. Look at their skin signs, color, temperature, moisture. Do they show signs of poor perfusion, shock? Do you want to have a partner get a blood pressure? If the patient appears unstable, you should be prepared. You should really be preparing for immediate transport after you do your initial interventions, right? The primary assessment is really all about speed and priorities. You want to find those life threats, correct what you can, and decide quickly, really, if the patient needs that rapid transport. So again, let's kind of just a recap again. So picking up where we left off, let's focus again on that circulation transport aspect. As you check your pulses, your skin signs, your mental status, you're really deciding two things at once, right? How sick is that patient? How quickly do you need to move? A cool, pale, sweaty patient with a weak radial pulse, anxiety, that tells you that perfusion is hindered, right? If blood pressure is low, consider cardiogenic shock, and avoid anything that could drop it even further. You really want to keep that patient calm, right? Minimize exertion and put the patient in a position of comfort. And again, usually it's going to be upright if they're short of breath. Unless they're altered or have hypotension, then you're going to kind of lean more to a supine or a shock position. If the story and the vitals really point to ACS, heart failure, and aortic pathology, again, you're not going to stay on scene. You're going to load that patient and go. Start care while you're moving towards your rig. A short scenario here, let's say you arrive to a 60-year-old with, some type of pressure type chest discomfort, clammy skin, thready radial pulse. You coach slow breathing, right? You apply oxygen if it's indicated. Prepare aspirin. Consider nitro if their blood pressure allows it and it's in your protocol. And then you're just rolling, right? With immediate threats addressed and transport plan in motion, you're really ready to gather your focused history. You're ready to go into your secondary, get more pertinent information. And again, all depends on what you want in whatever program you're in, on what your instructor wants you to do in terms of your assessment, but everything should have the same basic core components. So once that patient is stabilized enough to at least talk, you shift really into kind of a crisp cardiac focused history. You can start with your sample or OP-QRST. Let's go ahead and just do OP-QRST for now. So this is really going to give you a pain profile, the way it's set up, this OP-QRST right now. So onset. So when did the discomfort start, or what were you doing? Are there any provoking or palliating factors? So that means, does anything make the pain better? Does anything make the pain worse? The quality, can the patient describe in their own words what it feels like? Pressure, tightness, sharp, burning, tearing. Does the pain go anywhere else? So in terms of radiation, does it go anywhere else? The jaw, the back, the arms, the stomach. Can they point to one finger where it is the most pain? Since it started, has the pain come and gone, or has it been constant? Severity. On a scale of 1 to 10 or 0 to 10, 0 being no pain, 10 being the worst pain you've ever felt, what would you rate it as? And then timing, when did it actually start? If the patient says, oh, it started 3 hours ago, okay, it's noon right now. So that means around 9 a.m. it started. So really hammer down the actual time. And you want to tie that directly into your sample history or vice versa. That way you can capture the symptoms beyond just pain, shortness of breath, nausea, unusual fatigue. You want to look into their allergies. You want to ask pertinent positive and negative questions. You want to find out what medications they're on. What's their pertinent past medical history? When was the last time they ate or drank anything? And then what events led up to the call to 911. Now, you might have already got a lot of that information, so you could just use this time to reiterate and reaffirm what they've already told you, or to ask some follow-up questions, but you don't need to ask it just to ask it. You really want to be deliberate with your wording, and let the patient talk, right? Use short, open prompts. Those really work well. Like, tell me exactly what you felt first, or what were you doing when it started? The time of onset really matters here. Again, we're going to bounce a little bit back and forth, but because it frames your hospital options, right? So say it out loud and document it. If the discomfort has come and gone, confirm whether this episode feels different than their usual, like angina, for example. Keep your professional tone steady, reassuring, because again, your calm questions and calm demeanor reduces anxiety, and it's going to help get better answers from that patient. Uh, so your secondary assessment really connects the story of your exam, right? Start with a focused cardiac and respiratory check. Look at the patient's work of breathing. Listen for crackles that suggest there's fluid in the lungs. Inspect the neck for JVD, which is jugular vein distension. Look at the ankles for dependent edema. Those clues really point towards heart failure. Palpate pulses for regularity, for strength. Recheck blood pressures to look at trends. Obtain your SpO2s and titrate your oxygen as needed. And if your service, wherever you're working, uses cardiac monitoring at the EMT level, or if you're assisting paramedics, place the electrodes carefully on the chest and the body to minimize artifact. A clean tracing really helps the team downstream. Remember that none of this really should delay transport when the patient looks unstable, right? So let's say you have a 70-year-old with chest pressure, tachypnea, a faint crackles. Your exam supports ACS with early pulmonary congestion. So you keep them upright, you continue care, you call for a cardiac capable destination in your report. With your focus exam complete, the final step is really just building a plan to reassess frequently and then update the receiving facility. So reassessment is really where you prove whether your plan is actually working, right? For unstable patients, repeat vital signs at least every 5 minutes. For more stable patients, every 15 is more reasonable. But again, let the presentation kind of drive your pace. Trend the numbers, not just don't just look at single readings. Falling systolic pressure and nearing pulse pressure, increasing respiratory rate, tells you that perfusion is slipping, right? After any intervention, aspirin, nitro, CPAP, circle back quickly to see what has changed, right? Reassess mental status, skin signs, lung sounds, pain descriptors, severity. Get the patient to tell you in their own words how they're feeling. If they worsen, be ready to kind of pivot, adjust positioning, prepare the AED if obviously their status crashes, or involve ALS if they're available. Keep your radio updates succinct and focused on what the team actually needs to know. Chief complaint, onset time, vital trends, interventions given, responses, ETA. Really, a good reassessment makes your care just safer, your documentation stronger, and your handoff much more smoother. Okay. With those fundamentals kind of locked in, we're going to look into more specific treatment for chest pain. We're going to start with oxygen and kind of move on from there. Again, now that we've covered the assessment, let's talk about the care you can actually provide and the interventions. For patients with chest pain or just suspected ACS, one of the first steps is just positioning. Most patients feel best sitting upright, especially if they're kind of short of breath. But if they're hypotensive, though, you might want to lie them back more, right? But you always want to prioritize comfort and the patient's airway. Oxygen comes next, okay? But there's a specific key here, right? You don't give it just because, right? Current guidance is to titrate oxygen really to maintain an SpO2 in the 94 to 99, 95, 99, depending on your protocol. If the patient is already oxygenating well and doesn't appear in distress, you may not need to administer it, okay? But on the other hand, if they're pale, they're clammy, short of breath, oxygen can be beneficial. Okay. So once those basics are covered, now you can prepare your aspirin and then nitroglycerin if it's indicated. But keep in mind, your role is to follow your local protocol and medical direction. Some systems require direct orders before administering or assisting, while others allow standing orders, right? So let's kind of dive into each of those medications. Now, as EMTs, aspirin is actually one of the more powerful tools we have in the early stages of a heart attack. And really, it's sitting in nearly every medicine cabinet, right? Aspirin works by preventing platelets from clumping together, okay, in which that could slow the growth of a clot that's inside the coronary artery. It doesn't do anything to the clot. It doesn't dissolve a clot that's already been there, but it's just going to help keep the blockage from just getting worse. At the EMT level, the standard dose is between 162 and 324, 325 milligrams, usually given as chewable tablets so they can absorb faster. Always confirm that there's no allergy to aspirin, there's no history of major bleeding disorders. And again, this is covered more in pharmacology, so look at all those contraindications. If the patient has already taken some aspirin that day, just ask how much and note it in your documentation. Think of just aspirin as kind of buying time, okay? By reducing the clot progression, it will help preserve heart muscle until the patient can get that definitive care. It's really a small intervention with a potential big impact. You don't expect the patient to start feeling better after you've given them aspirin, right? It's really just there to hopefully not make the situation even worse. Now, nitroglycerin is a medication that many cardiac patients are going to carry with them. It comes in these little small tablets, sprays, sometimes in patches. But at the EMT level, you don't administer nitro on your own. Okay, you assist patients with their prescribed medication, again, if your local protocol allows it. Nitro works by dilating blood vessels, which just reduces the heart's workload and improves blood flow to the myocardium. Now, when the coronary arteries widen, that chest pain is often going to improve. Okay. When you're assisting with the nitro, make sure you're following the nine rights or six rights, whatever rights you're learning. Right patient, right medication, right dose, right route, right time, right documentation, right to education, right response, and right to refuse. Okay. Confirm the prescription belongs to them. Check the expiration date. You want to dice it. Remind the patient to place the tablet under the tongue, let it dissolve. Don't chew it, don't swallow it. And then it's also good practice to tell them of the potential side effects. Again, if the patient is unaware of them, that way, if they do start feeling a little bit lightheaded, a little sublingual burning, something like that, that they're not going to have anxiety about it. So now here's really how nitroglycerin works in just kind of simple terms. It relaxes and widens the blood vessels. Nitro is going to lower the amount of resistance the heart has to pump against. That means the heart doesn't need as much oxygen to do the same job. At the same time, the dilation of the coronary arteries help deliver more blood to the heart, and more specifically the heart muscle, right? The combination of the less demand, more supply can really make the difference in relieving the chest discomfort. That's why patients really often feel the relief within minutes of taking a dose, right? It's important to explain again to the patient what's happening. You might say the medicine will help open up your vessels, ease the workload on your heart. Giving that reassurance is going to help build trust and again reduce that anxiety. Again, nitroglycerin, very powerful. There is those side effects, and you have to anticipate them. Most common is going to be that drop in blood pressure. Because those vessels dilate, pressure can fall rather quickly, which may leave the patient feeling dizzy or weak. And that's why we always check a systolic blood pressure before and after each dose. Most protocols require it to be at least 100 millimeters of mercury systolically before giving nitro. Another effect is pounding headache, since the dilated vessels in the brain also increase blood flow. Some patients notice that burning sensation under the tongue. And again, that's all normal, and it just tells you that the medication is actually working. You may also see changes in a patient's pulse. It can either go faster, slower, really depending on how the body's actually reacting. Always be prepared to manage dizziness or even a syncopal episode after nitro, and just keep reassessing. Now, this slide focuses on when not to use the nitroglycerin. All right. So first, if the patient's systolic blood pressure is over 100, nitro can make it drop dangerously low. Second, if there's a head injury, because lowering pressure in that situation can actually worsen the outcomes. Third, if the patient has used any type of sexual enhancement drug, again, male or female, Viagra, Levitra, Cialis, in the past 24 to 48 hours, combining them with nitro can cause, again, life-threatening hypotension. And again, don't assist if the patient has already taken the maximum prescribed dose, which is going to be usually 3 within 15 minutes. Again, these aren't just like, fine print, they're patient safety issues, right? If a patient with chest pain says they took 2 nitro already and their pressure is 92 systolic, and they mentioned taking Cialis last night, red flags. Don't give nitro. Instead, focus on aspirin, oxygen if it's indicated, calm reassurance, rapid transport. And again, always remember, like if you're ever not sure what to do, or if there's like a gray area or everything's borderline, just stop and just talk with medical direction. So now let's shift gears into cardiac monitoring. At the EMT level, again, you're not going to be interpreting 12 leads, right? But you may be involved in applying the electrodes and helping the team collect just a clean tracing. The key point is that monitoring is only as good as the electrode placement. If the pads are off, or if there's too much artifact from movement or poor skin contact, the tracing can be misleading. So just think about it this way. If you're handling or just handing a patient over a patient with suspected ACS and the hospital pulls up a messy ECG because the leads were crooked or loose or whatnot, they can delay decisions. So your role is to ensure that the setup is right. It's about giving the next provider the best information possible. So now, good electrode placement, right? That comes down to just preparation. First, you want to shave any excess chest hair where the pads are going to go. The electrodes need to be able to stick directly to the skin, not and it's hard over the hair. Second, to clean the skin with an alcohol prep pad to remove any oils or dirts, then let it dry. Third, attach the cables to the electrodes before sticking them on the patient. It reduces the tugging that can pull them loose. Finally, double check placement before turning on the monitor. Wrong position equals wrong data, right? A helpful tip is just to think ahead. If you're bouncing down the road in the back of an ambulance, electrodes are more likely to pop off. Taking an extra 30 seconds on scene to prep the skin and secure them can actually just save frustration later. But again, it all depends on what the paramedic would like to do. But small steps like these just make a big difference overall in the quality of care and the confidence your team has in that tracing. So this slide just shows the placement of the limb electrodes and those 6 leads for that 12 lead ECG. For the limbs, 1 electrode goes on each arm and leg. Okay. For the chest, V1 is going to be at the 4th intercostal space to the right of the sternum. V2 mirrors it on the left side. V4 is going to be at the 5th intercostal space on the midclavicular line. V3 sits between V2 and V4. And V5 and V6 just extend outward towards the mid-axillary line. So your V6, V5 is going to be still at the 5th intercostal space, anterior axillary line, and then V6 is going to be mid-axillary line, but still at that 5th intercostal space. So again, you don't need to memorize every detail as an EMT, but knowing the general locations really helps when you're assisting a paramedic or a hospital team, okay? Just as important is minimizing that artifact. Movement, talking, patient shivering can really all mess up the tracing. So sometimes simply coaching the patient to hold still and breathe normally makes all the difference. Now, once the electrodes are in place, it's time to actually check your work. Turn on the monitor, run a short strip, and again, look for clean, steady lines, right? So if you see a lot of squiggles or interruptions, troubleshoot, right? Check the loose cables, poor adhesion. Maybe the patient was moving. So don't underestimate how much accurate monitoring matters, right? A good tracing can really help receiving teams identify a STEMI, which means faster interventions and better outcomes. Whereas a bad tracing can delay decisions or even lead to misinterpretation. Okay. Now, at the EMT level, your focus is not on reading the ECG, but it's really on making sure it's reliable and artifact free. So think of yourself as setting the stage for the next provider to do their job well. With monitoring covered, let's go ahead and move on. Now, some of your patients will have a history of heart surgery, and it's helpful to recognize what that means, right? The two most common procedures is going to be a CABG or a coronary artery bypass graft, or a PCI, a percutaneous coronary intervention, also called stenting. So a CABG is the open heart surgery where vessels are essentially grafted to bypass blocked coronary arteries, whereas a PCI, a little bit less invasive. It's essentially a balloon is inserted into the artery to open up, and then the stent is placed to kind of keep it propped open. Now, as an EMT, your takeaway is simple. These patients still have heart disease. Just because they had a bypass or a stent doesn't mean that they can't develop chest pain again. In fact, they pretty much remain a high risk for angina, MI, or heart failure. You also may notice a scar on the patient's chest from surgery, but your assessment and care remain the same. Calm reassurance, aspirin, nitro, again, if indicated, oxygen, if indicated, and rapid transport. Now, a patient might also have an implanted pacemaker. Okay, now these small devices implanted under the skin, usually kind of by the left clavicle. Their job really is just to keep the heart beating at a steady rate when the natural conduction system really isn't reliable. Some patients rely on them continuously, while others will kick in when the rate kind of drops too low. In the field, you might notice a small bulge under the skin where the device actually sits. Patients often carry a card identifying their device. If you're doing CPR, just avoid placing the AED pad directly over the pacemaker and just shift it slightly to the side. It's just important to remember, having a pacemaker doesn't make a patient, immune to a cardiac emergency. They can still develop ACS, dysrhythmias, or even just straight up cardiac arrest. So if you suspect a pacemaker malfunction, like a patient with dizziness, weakness, a syncopal episode, treat it like any other cardiac call, transport promptly. Now, pacemakers themselves are generally reliable, but again, they can fail, they can malfunction. When that happens, the patient will complain of lightheadedness, dizziness, fatigue, fainting. Their pulse may feel irregular, very slow. Sometimes they'll describe it feeling as if the device isn't kicking in, right? So for EMTs, you don't really troubleshoot the pacemaker, right? You support the patient, provide oxygen if it's needed, monitor the vitals, prepare for transport. If the patient is unstable, becomes pulseless, you're going to manage them like any other cardiac arrest type patient. Start your CPR, use the AED, keeping the pads placed slightly, again, away from that device. Also, treat the symptoms, right? Not just the presence of a pacemaker. The fact that someone has one means they already have significant heart disease. So when in doubt, just err on the side of caution and just transport quickly. So here's what an actual pacemaker looks like, but again, it's going to be under the skin. You have like these little wires running to the actual heart. For you in the field, the main point is just recognition. If you see the outline of the device under the clavicle, you know that the patient has a cardiac history and is being electrically supported. And remember, to adjust the AD pad placement, just you're not directly on top of the device. Pads can go slightly higher or more lateral as long as they maintain good pathways across the heart. Also keep in mind that these patients may feel the device pacing. They sometimes describe it as kind of like a mild thumping sensation in their chest. That's completely normal. But if they're symptomatic, weak, dizziness, faint, you still treat them as unstable. Okay. The picture here is just to remind you that technology can really help people stay alive, but it doesn't eliminate the need for EMS care. You can also have what's called an implanted cardioverter defibrillator, okay, or an AICD. They're similar in appearance to a pacemaker, but they have an added function. They're going to monitor the heart rhythm and deliver shocks when a dangerous arrhythmia like ventricular fibrillation or ventricular tachycardia just happens. Um, Patients often describe a feeling sudden hard like kick in the chest when that device actually fires. If you arrive on scene and the patient says their defibrillator has gone off, just take it seriously. Sometimes it means the device corrected the rhythm successfully, but sometimes it's just a sign of ongoing like, instability. Treat the situation like any other cardiac emergency. Assess, provide oxygen if it's indicated, prepare aspirin, nitro if it's appropriate, and then transport. One key point, if an AICD delivers a shock while you're touching the patient, you may feel a slight jolt, but it's not enough power to actually be harmful. So don't let that stop you from providing actual care. Also remember that these patients are high risk. They need prompt evaluation, even if they're feeling better after that shock. Um, this slide introduces the external defibrillator vest. You might hear it called a life vest. It's a wearable device that continuously monitors the heart and delivers a shock if a lethal rhythm is detected. Patients who are waiting for like a permanent implant or who are too unstable for surgery, they're going to often use these types of vests. As an EMT, your role is mostly awareness, right? If the vest so the vest has an alarm, so if it starts going off or delivers a shock while you're present, just stay calm and just keep providing care. You don't remove the vest unless it interferes with CPR or the AED pad placement. In those cases, you follow your local protocol, but generally just keep it on. Think of the vest as kind of like a temporary external AICD. It protects high-risk patients outside the hospital. Your job is just to recognize it, explain to the family or bystander that it's normal for it to alarm, and then manage the patient as you would any other patient with chest pain or cardiac arrest. Then we have a left ventricular assist device or an LVAD. There are mechanical pumps that help the left ventricle move blood into the aorta. They're usually implanted in patients with severe heart failure or who are pretty much awaiting a transplant or who need long-term support. Okay. What's important for EMTs is that many LVAD patients won't have palpable pulses because the pump just provides continuous flow. That can be kind of disorienting, so you may not feel a radial or carotid pulse, but the patient may be awake and talking. In these cases, really rely on mental status, skin signs, blood pressure, to kind of see how their patient's actually doing. Always transport LVAD patients with their power sources, spare batteries, and the controller. If the device alarms or malfunctions, your job really is just to support ABCs and call ahead to that receiving facility. These patients, again, high risk, and they always warrant rapid transport. Now, with these devices covered, we're ready to shift into cardiac arrest. So now, cardiac arrest itself is just the sudden loss of effective cardiac function, right? The heart may be quivering in like ventricular fibrillation, it might be racing ineffectively in ventricular tachycardia, or silent in like asystole. But whatever the rhythm, the result is the same. No pulse, no perfusion, and again, there's no time to waste. For EMTs, the priorities straightforward. Start high quality CPR, minimize interruptions, and apply that AED as soon as possible. Every minute, every second without compressions or defibrillation really decreases the survival chances of this patient. So remember, sudden cardiac arrest often occurs in the setting of an acute MI, but it can also happen with just heart failure, arrhythmias, or structural problems like a dissection. So that's why it's really that's why your awareness, your scene awareness, quick assessment, and decisive actions so critical. The AED, so the automated external defibrillator, again, is one of the more powerful tools you'll carry. It analyzes the patient's rhythm, and if it's appropriate, it delivers a shock to correct ventricular fibrillation or pulseless ventricular tachycardia. Most models are semi-automated, meaning you'll press the shock button when prompted. Some fully automated and deliver the shock themselves. Okay. The real beauty of the AED is that it requires like very, very little training to use it effectively. Okay. Voice prompts are going to guide you step by step, which means that even a layperson can operate one successfully. Your responsibility as an EMT is to apply it quickly, follow the prompts, and ensure compressions resume immediately after every single shock. Think of the AED as just like the bridge between, really the bridge between your CPR and the hospital's more advanced care. Without it, a VF or pulseless VT are pretty much almost always universally fatal. With it, survival becomes just possible. AEDs themselves, they come in different shapes, different styles, different sizes, but different brands. But again, they all have the same exact purpose. Some have simple diagrams with just two pads and a shock button. Others have more advanced displays that actually show you the rhythm strip. Some models are designed for public access, while others are more built for, into EMS monitors. But don't get hung up on the differences, right? The overall key is just to stay calm, follow the prompts, and then focus on minimizing interruptions in your compressions. Make sure to place the pads correctly, one on the upper right chest, one on the lower left chest, and let the machine do the analysis. As an EMT, you're not diagnosing the rhythms, right? You don't need to interpret, but you do need to ensure that the AED is applied quickly, correctly, and integrated smoothly into your resuscitation efforts. So let's talk about why AEDs have such have been such a game changer for EMS. First, they deliver shocks quickly. You don't need to spend precious minutes interpreting a rhythm. The machine does it all for you. Second, they're really simple to use. Voice prompts walk you through every step, so there's no confusion even under pressure. Third, the AED pads provide a better connection than those old-fashioned paddles, so shocks are delivered more effectively. Also, for you, this just means more focus on what really matters. High quality compressions, minimize interruptions. Every second counts, right? The AED allows you to work more effectively, more efficiently, keeps compressions going, and deliver defibrillation as it's indicated, right? Just think of it as another partner on scene with you. It analyzes, you compress, and together you give the patient the best shot for survival. Now, it's important to remember that not all cardiac arrests are shockable, okay? AEDs are designed just to shock ventricular fibrillation and pulseless ventricular tachycardia. They won't shock asystole or pulseless electrical activity, which is a PEA. Asystole is essentially a flat line. No electrical activity, and that means there's no electrical activity to reset. A PEA is when you see an organized rhythm on the monitor, but there's no pulses, and that means there's no pumping. In both of these cases, a shock won't help. Now, what the patient needs is high-quality CPR, rapid transport, and ALS interventions. So, don't get discouraged if the AED says no shock advised. That doesn't mean you stop. It just means compressions and good BLS care are the only therapies proven to help until advanced care arrives. So now the chain of survival, right? So the chain of survival is a kind of simple but really powerful concept. It was the critical steps that need to happen in order for a patient in cardiac arrest to survive. The first link is early recognition and the activation of EMS. Someone has to call for help right away. The second is immediate high-quality CPR to keep blood flowing to the brain and to the heart. The third is rapid defibrillation. This is where the AED comes into play. The fourth link is that advanced life support, and it's provided by paramedics or in the hospital setting. And finally, the last link is that post-arrest care. Things like targeted temperature management, cardiac catheterization, that's going to give the patient the best chance at full recovery. Every single link of this matters, okay? If one is weak, the whole chain can break. So as EMTs, you're often responsible for that second and third link, CPR, defibrillation. And sometimes you influence that, the first, by training the public or reassuring family members to call 911. So again, here you have just a visual representation of those 6 links in that chain of survival. And again, each link flows into the next. And it kind of just reminds us that cardiac arrest survival isn't about one intervention. It's about the system working, okay? And more specifically, working together. As an EMT, your strength is in early links, right? When you arrive, your CPR quality and speed of the AED application. That's directly going to impact whether the later links even have a chance to work. A hospital can only provide advanced care if you deliver a patient with a viable rhythm. This is why even basic steps, compressing at the right depth, the right rate, minimizing pauses, placing the pads quickly, so vastly important. So again, you're not here just to check a box. They're here, they're life-changing decisions that have life-changing outcomes. So why is defibrillation such a big deal? I mean, I feel like we've covered that pretty in depth, but let's keep it going. It's because ventricular fibrillation, the heart is just quivering electrically, right? The longer it goes, the more of those cells will burn out, and the less likely a shock will actually work. Studies have shown that every minute defibrillation is delayed, survival chances drop to about 7 to 10%. Okay, CPR buys time by pushing a little blood through the system, but only defibrillation can actually reset the heart into an organized rhythm. That's why AEDs are in airports, malls, schools. They let someone deliver that first shock within minutes, even before you arrive. Okay, as EMTs, your job is to just keep that chain unbroken, right? Start your compressions, get the AED on quickly, minimize the pauses around each analysis and shock. That simple formula, compressions and shocks, has saved thousands of lives. So after the AED delivers the shock or decides that no shock is needed, the next step is simply, and the next step in the chain is simply advanced care. ALS providers, your paramedics, nurses, doctors, they take over with airway management, IV medications, sometimes advanced procedures like, intubation, synchronized cardioversion, pacing, defibs. Post-ROSC care is also important. If the patient regains a pulse, hospitals may use what's called targeted temperature management, advanced blood pressure support, and cardiac catheterization to reopen those blocked arteries. So why do you need to know this? Well, it's really because your actions, right? Your actions set the stage for everything. If you deliver high quality CPR and defibrillate quickly, you give the patient a fighting chance for the hospital's interventions to actually work. Without your link in the chain, the later links, they don't matter. So, integrating CPR with the AED is really all about minimizing interruptions. When the AED says analyzing, you need to stop compressions just long enough for that machine to read the rhythm and then get right back on that chest. If a shock is advised, make sure no one is touching the patient, deliver the shock, and then again, immediately resume chest compressions. You really don't want to pause to check for a pulse until the AED tells you or until you've completed a full cycle of CPR. This rhythm, compressions, brief pause for analysis, shock if indicated, compressions again, is really what keeps the blood moving and gives the patient the best chance for survival. So think of the AED as just your partner. It checks the rhythm, you keep the blood flowing, and together you're buying time until advanced care arrives. And hopefully you're going to have the best outcomes for the patient. Now, AEDs are only lifesavers if they're actually working when you need them to work, right? That's why regular maintenance is just so important. Follow the manufacturer's recommendation for daily or weekly checks. Confirm that the batteries are charged. Pads are in date, so they're not expired. They're sealed, and the unit powers on without any errors. If the AED actually fails in the field, it's not just inconvenient; it can actually cost someone's life. Right? So always document any issues and take the unit out of service until it's repaired or replaced. As an EMT, you may not be the one scheduling the services, but you are the one checking that the machine in your rig is ready for the next call. Okay. Really, reliability is like the biggest thing that's not negotiable, right? And there's this whole follow the manufacturer guidelines for pretty much any piece of equipment you're going to use in the field. Now, every EMS systems AED program operates under medical direction. Okay, that means the protocols are approved by a physician, and EMTs are trained to follow those specific guidelines. Okay, this really ensures consistency and safety across the entire system. Continuing education is also part of that equation. Skills like CPR and AED use are perishable, right? They need to be practiced regularly to stay sharp. That's why your department will run refreshers, skill checks, mock codes, and you really need to take those seriously. When the real call comes, muscle memory and confidence are what allow you to act fast without second guessing yourself. And then remember, AEDs can save lives, right? But only when the system is strong. Good protocols, good training, good overall teamwork. Now, when you're preparing to use an AED in the field, safety obviously comes first. So make sure that the patient isn't lying in water, right? Not in snow or on a metal surface that can actually conduct electricity. You want to quickly dry the chest if it's wet. If the patient is wearing a nitroglycerin patch, remove it and wipe the skin before applying the pads. Otherwise, the patch can cause burns when the shock is actually delivered. If the chest is very hairy, the pads may not stick well, and they're not going to have enough surface to skin contact. So you may need to shave a small area or apply a set of pads and then rip them off to remove the hair, and then apply the fresh set. These are just quick actions, but they matter for getting good contact, right? Finally announce, I'm clear, you're clear, everybody's clear before pressing that shock button. So, and that's the whole point of that, is to make sure no one is touching the patient when the defibrillation occurs, right? Just these little small safety steps can keep you, your crew, and your patient safe. This slide just continues with a few more prep points for the AED use. So in addition to removing any nitroglycerin patches and shaving, think about the big picture. What caused the arrest? Was it a sudden collapse in a middle-aged person with a history of chest pain? Or was it a trauma? Was it a drowning? Was it an overdose? Knowing the likely cause can help you anticipate complications and guide your report. Also consider your resources, right? If you're in kind of a tiered system, request ALS early so they're on the way while you begin your BLS care. Don't delay CPR, don't delay the AED use. Those should come first, but loop in that higher level of support as soon as possible. It's important to remember, even in systems with paramedics, EMTs are often that first one on scene. So your immediate actions, just purely the compressions, AED use, airway management, that's what's going to buy time until advanced care actually arrives. Here you can see like a little, not just for the AED, but a whole CPR kind of algorithm, if you will. It's very straightforward. Specific for the AED, you want to attach the AED pads as soon as possible while CPR is ongoing. When the AED says analyzing, stop compressions, clear the patient, let the machine check the rhythm. If it advises shock, make sure everyone is clear, deliver it, resume CPR. Now in 2 minutes, it'll reanalyze and say, hey, shock advised, shock no advised. So just go along with your CPR protocol with whichever American Heart Association, American Red Cross, whatever entity that your guys are covered under. So now after the first shock, okay, there are 3 possible outcomes. Okay, the best is return of what we call spontaneous ventilation. So we call that ROSC. Okay, the patient regains a pulse, they start to breathe more effectively. Awesome. In that case, you immediately shift to post-ROSC care. Support the airway, provide oxygen, monitor vitals, prepare for transport. The second possibility, no pulse and no shock advised. That means the AED detected a non-shockable rhythm, like asystole, a PEA. Your response, continue CPR, transport, and then again, involve ALS if it's available. The third, no pulses with a shock advised again. Deliver the shock, resume compressions. You're going to keep on repeating that cycle every 2 minutes, right? Don't stop to check for a pulse after each shock. Just go right back to compressions unless the patient, again, shows signs of obvious life. These outcomes really frame your decision making and keep care organized under just a crazy amount of stress. When do you begin transport during a cardiac arrest if ALS isn't available, right? Now, your guidelines kind of suggest moving the patient when one of three things happen. Okay. You have a return of spontaneous circulation, you delivered about 6 to 9 shocks without any success, or you've gone through 3 consecutive no shock advised analysis without a pulse. Okay. The idea is to balance staying on scene to provide high quality CPR and defibrillation with the need to get the patient to more advanced care. In some systems, local protocols may be more specific. So again, always follow your local medical direction. Okay. Now, as an EMT, keep in mind that quality compressions on scene often provide better outcomes than a rushed move to the ambulance with poor CPR. So really just make your decision based on the patient's response, your crew's resources, and again, above all else, is going to be your local protocol. Now, sometimes cardiac arrest actually happens during transport. Okay. In that situation, safety should be your first concern. If you need to deliver a shock, you need to stop the vehicle. Trying to analyze or shock while the ambulance is actually moving is just unsafe for you and it's really ineffective for the patient. Once stopped, just follow the sequence. Analyze with the AED, shock if indicated, and then again, immediately resume your compressions. After each cycle, just decide whether to continue your transport or pull over again for the next analysis and shock. So this can be kind of challenging in the field, but again, your priority should always be high quality CPR, safe defibrillation. We kind of think of, so let's say you're transporting a patient with chest pain, right? They suddenly become unresponsive, pulseless. You stop the ambulance, move them flat, start CPR, attach the AED, and then follow the prompts. That calm, systematic response really is going to make the biggest difference. So this last step in this section is really coordination with ALS. Okay, when paramedics arrive, your role shifts from simply leading the resuscitation to becoming part of the actual team. Keep compressions going until you're asked to switch and be ready to give a quick, clear handoff. Okay, when the arrest happened, how long CPR has been going, how many shocks were delivered, what meds the patient may have been taking, and any return of pulse or breathing did you notice. Okay. The key is to really never delay defibrillation or compressions while trying to just make room for ALS, right? They'll bring advanced airways, IV meds, cardiac monitoring, but those only again work if you've already kept blood moving with high quality CPR and AED. So think of ALS as adding layers to what you've already started, not replacing it. Smooth teamwork is going to make the huge difference in the outcome of the patient. So really just stay calm, communicate clearly, and focus on the patient care above all else. Now, ROSC, okay, return of spontaneous circulation. Great, but it doesn't mean the job's done, right? When a patient regains a pulse, your focus really shifts to supporting that fragile recovery. Start by checking respirations. If they're inadequate, assist with the BVM at about 10 times per minute, which is one breath every 6 seconds. Provide oxygen. But again, titrate it so the SpO2 is between 95 and 99%. Avoid blasting with high flow oxygen unless the saturation is low. Check blood pressure and support circulation as best you can. You just really want to continue to monitor pulses, mental status. Sometimes ROSC is just temporary and the patient may slip back into an arrest. So be ready to resume CPR really at any time. If the patient is following commands, they're stable, that's great. But again, transport remains a top priority. If ALS isn't en route already, start towards the hospital right away, notifying the receiving facility so they're ready with post-arrest care, like a cardiac catheterization or temperature management. Okay. Now, that concludes this chapter. Okay. It's a whole lot on one of the most prevalent issues that faces our patient population. So, thorough assessment, rapid identification, rapid intervention, rapid transport. That's going to be the key. Really appreciate it, and I'll see you next time.